Hi, everyone, and welcome. It is Wednesday night, and this is the My Baby Experts show, and I am your host, Shari Criso, and I am so excited to be with all of you here tonight. I hope you are all jumping onto the stream, and I hope you also all got your instant messages, and I hope you like that, something new that we're trying out to give you that heads up reminder that we're about to go live, and especially tonight, because this is one you don't want to miss. So I'm about to pull up my stream to make sure that you're all jumping on, not having any issues, and that you don't miss a thing, because boy, do I have a show for you tonight. Super excited. So we're going to give everybody a chance to jump on, and I'm going to, let's see here. Here we go. Awesome. Thank you, Joe. Thank you. Okay, so here we are, and again, I am Shari Criso. I know we have a lot of new people, and so I wanted to just take a moment, introduce myself. Yes, there's all my favorite people jumping in here. Hi, ladies. Hi. Okay, so tonight we have a really special event, and I want to just say, you know, for those of you guys who don't know me, we have had so many people register for this event. It's insane. Thousands, like literally, I think almost 2,000 registrations. So we'll see how many people we have on here live tonight. I know a lot of people weren't able to watch live, but we'll talk about what to do for your replay and make sure that you all get that. And also, we have a lot of new people on our page. We just hit 100,000 followers just today. And I'm thinking, what a perfect day for that to happen. What a perfect day. And so I'm blessed to have all these moms and dads and everybody from around the world just coming together to be able to learn about all these different topics. So again, if you don't know me, I am a registered nurse. I'm a certified nurse midwife. I'm an international board certified lactation consultant, and I've been working with moms and babies for over 25 years. I don't talk about more than 25. We say over 25 these days. And so I've been doing it in pretty much every capacity, through pregnancy, through birth, through breastfeeding, and everything in between and beyond. And, you know, what I do here is a way for us to connect with you, bring you the best, most incredible experts in all different fields, and just give you the information and the knowledge that you need to make the very best choices to have the healthiest families and babies and lives. And so that is the goal here, and that's what we're doing. And I hope you really, really enjoy it. Yes, hi, you're looking forward to learn. And we're looking forward to teaching you all. So this is great. I'm going to go ahead and bring on my expert panel because I have some amazing, the top people doing this, and the privilege of being able to be with all of them tonight and to have them here for you on this live free event that everybody gets to sit in their pajamas. Hope you're all home being comfortable and just learn. And we're going to be doing this for the next 2 hours. So let me bring them on and we'll get started. So hold on one second. Give me 1 minute here. All right, one by one, they are going to start popping onto the screen and unmute. All right, here we are. Hi, guys. Oh, unmute everybody. Hold on. All right. Hi, guys.
Hi, Shari.
Shari.
Here you all are. Fantastic. Welcome to the show. I am so happy to have you here.
Happy to be here.
That's
Thanks
great.
for inviting us.
Very happy.
Thank you.
Of course. No, this is something that we had all discussed individually for a few months, and had a couple of shows earlier, beginning of the summer and through the summer with Scott and Lisa and Michelle. And this was just, we thought this is going to be the best way. Let's see, can they see you? Hold on, let me make sure I'm getting you into the right. Looks like I may not have you on the screen.
Oh.
Let's see, can they see you now? Give me 1 minute. Let me just make sure that you're all on here with me. Yes, I'm bringing them all on right now. I don't know why. There they are. Now we're doing the Brady Bunch, okay? We're referring to this as the Brady Bunch style because there's so many of us here tonight. But over the summer, we did a couple different shows, and we talked about all coming together for this important panel, as we're doing now, to discuss tethered oral tissues, tongue, lip, and buccal ties, and what that means for parents, and just basic information that moms and dads and also professionals could learn from so that they can bring it into their own practice or into their own lives and just have that knowledge. So the fact that you could all come here together and from all different disciplines is really the best part of what we're doing here as a panel, because it really takes a team. And what you see here what everybody sees right here on the screen is really the team. You all work together on a regular basis. And so it's really the team here talking about how you interact and how this really takes not just one person to deal with. So what I want to do right now is, first of all, ask the audience where everybody is from, because we really have viewers from all over the world, and I want to just know where everybody's from. So go ahead and type in where you're from, what your specialty is. I see someone here saying she's from Houston. She's a pediatric dentist. Thank you for organizing. Thank you for coming. That is fantastic. That's what we were looking for. So glad to have you here. Yes. Wonderful. All right. And if you see me posting in the stream, just so you guys all understand how this works, I'm not typing. I'm not that good. Okay. That's Joe. Okay. Joe is actually typing for me. He'll be putting up information as we go along tonight. There'll be, links that we may want to post, especially links to everybody here's their website so that you could get more information. And we'll also describe, most of you did register for the event. When you go back to that registration page later, there'll be links to everybody's sites, links to everybody's Facebook pages, as well as some amazing gift downloads that they all generously provided to you, and you'll be able to download the information over there. So if you registered, you'll get all that. Plus, you'll be able to watch the replay, okay? And so just make sure if you didn't register that you do, and Joe will post the link again into the chat room. So let's start with some introductions, and tell us about yourself. I'd love for Scott Siegel, if you could just start and let everybody know who you are. And
Sure, I'll make it pretty brief. Basically, I'm Scott. I am a board-certified oral and maxillofacial surgeon. I am both a physician and a dentist. I'm an MD and a D.D.S. And I have been really focused on the diagnosis and treatment of tethered oral tissues, or tongue tie, lip ties, and buccal ties, really for the past 17, it's going on 18 years now, as my primary area of specialty. My background, how I got into it, I basically was mentored in medical school and in my surgical residency, and then afterwards in private practice by a well-known tongue tie pioneer, Elizabeth or Betty Carrillos, who developed one of the classification systems that we use for tongue tie. And I basically, I lecture internationally on the subject, I publish on it, and currently involved in clinical research that we're getting up and running in conjunction with Columbia University, which we'll be announcing at some point shortly. But getting objective data and really trying to get a lot more science behind what we do, which we'll talk about later. But I'm based in New York City and on Long Island in New York, and this has been my passion, and I think it'll come out tonight. And I'll pass the baton along here.
Awesome. Lisa?
Hi, Shari. First, I just want to say thank you, Shari, for organizing this, because we all know how important it is to get this information out. And your reach is amazing, and 100,000, that's so cool. So I'm an IBCLC certified nurse midwife. Much like Shari, we have about the same letters after our name. We have a lot in common. Like her, I started out as a nurse, and then I was a midwife for a while, delivered babies. I've worked in various ways with moms and babies for about the last 30 years. Now in private practice in Staten Island, New York, basically doing mostly lactation, women's wellness, functional integrative medicine with women. And but as an IBCLC, I came to feel how important this was when there were certain babies that I just couldn't help. And I didn't really learn about tongue tie and lip tie in school or in any of my studies for learning to be an IBCLC, to be a lactation consultant. So I reached out, I did my own research, and I met a group of people who were doing this. So since that time, which was about 5 or 6 years ago, it's been a focus of my practice and learning as much as I can. And I'm fortunate to be able to refer my babies that need revision to Dr. Siegel. Not everybody's that fortunate, so that's great. And working together in a team is the priority to me. So this is really exciting.
Awesome. Awesome. Thank you. Nancy.
Hi, Shari. Thank you so much for inviting me to this esteemed panel. My name is Nancy Calamusa. I am the owner and director of New Jersey Pediatric Feeding Associates. We're located in East Brunswick, New Jersey. I am a speech pathologist who specializes in pediatric feeding and swallowing issues. I have an entire team at our practice of lactation consultants, ENTs, speech pathologists, CVI specialists. We take a whole team approach to help these babies learn how to eat. And just like Lisa said, for years, 30 years to be exact, I have been doing this as well. And there were those children that we just couldn't seem to move along quick enough based on our education and our training in graduate school. I had great mentors and I worked in the best places in terms of NICUs for a long time. But we just couldn't get these kids to sort of progress and get out of the NICU fast enough until I started to do a little bit more research, and we found that when there was a problem, there was a significant reason why these kids weren't moving along. So I was lucky enough to meet all of you, and here we are today. So thank you.
Thank you. Fantastic. Michelle.
Hi, Shari. Thank you. And I am also grateful to be here, and thank you for organizing it, because it might seem easy to get a couple of professionals together and organize this, but I know it's a lot of work. So my name is Michelle again, and I'm an occupational therapist, and I emphasize and specialize in the pre-crawling baby. And I was a hospitalist, worked in the hospital in all different kinds of settings, NICU, PICU, CICU for 20 years, and I've been in private practice for 2. And I also work in a team approach in the private practice arena and see a lot of babies with tethered oral tissues. I created the tummy time method about 10 years ago, and that's a great way for babies to work on posture, movement, and connection. And that's about it.
Fantastic. Thank you. And Jackie.
Hi, Shari. Thank you so much for having this great expert panel. This is so fun. I'm so happy to be here. Thank you. So to introduce myself, my name is Jackie. I have my doctorate degree in physical therapy. I am certified in craniosacral therapy, and I'm also certified in neurodevelopmental treatment. My background, I've worked in a lot of different settings. My favorite has always been working with the family. So moms, babies, and, the entire family unit, how to help everyone, to allow that baby to function better. So I've had the opportunity to do a lot of in-home work and do a lot of early intervention. I've also worked in schools, public and private schools. So I've worked with typically developing children and children with neurodevelopmental challenges, which is really nice to kind of see both ends of that. I currently have had my own practice since 2008. I was doing in-home work, and then I was working in Denville, and 2 years ago I moved to Red Bank, New Jersey, so that's where my practice is located. And I work throughout the lifespan, really, with my treatment, but my primary patient population is babies with tethered oral tissues. And I am also very blessed, being in New Jersey, that I get to work with Nancy and Lisa and Scott. So it's really great that we have great people around us to help and refer to. So thank you so much. I'm excited to share any information that might be helpful.
So wonderful. Thank you all. As I was listening to you all speak, and, I know what we were putting together tonight, but to hear you all describe your vast experience in different areas and what this really means for people out there to hear this, it was hitting me as well. And just like you said, Lisa, throughout school, I went through midwifery school. I'm an IBCLC, and yet I did not have this information. And I really want to stress that, because with all the, courses that we took, I even look back and think of how much I missed in the diagnosis, in the assessment, and just being able to understand what was actually happening for these babies and for these moms. And just from knowing all of you, just the last few months, how much I have learned from all of you. I feel honored to have you here with me and to be able to bring this to everyone because it's so critically important. And I'm you know, we're not different. I feel like I'm just learning the basics right now. So it's great. It's really great. And I'm going to learn a lot tonight, I'm sure, as you're all speaking. So let's start a little bit with what are we even discussing? Tethered oral tissues. What does that even mean? What are we referring to when we say that? And anybody who wants to go ahead and jump in.
So I can start with that. Tethered oral tissues can be, and we all have frenums that attach our tongue to the bottom of our mouth, to our lips to our jawline, but they shouldn't be restrictive. So a tethered oral tissue is a frenum that restricts movement. And maybe Scott can give us a little bit more technical definition than that. But in my work, what I feel that tethered oral tissue is a functional as well as just a diagnosis of what it looks like. So the function of it not being able to, it preventing normal function is what tethered means to me.
Great. And those tethers can be in different areas because we talk about tongue ties, lip ties, but these are, what we're referring to different areas of the mouth.
Right. So under the tongue, right? Scott, go ahead, your turn.
I was going to say, traditionally speaking, we're all, basically talking about lip ties, that little piece of skin, if you want to call it, that connects the lip to the gums. So that area underneath the tongue, what we traditionally talk about as a tongue tie. And then there could be potentially ones in the cheek areas. So see, we'll maybe show some slides later on. But you can have these little webs or these little tethers, as we now call them. We always used to term it tie, but the term tethered came out in, I think it was in Montreal in 2013, Kevin Boyd. We got to give credit to, because he really kind of set that in motion here, and now everybody's taken this terminology as far as the acronym TOTS. So it kind of is an all-encompassing acronym that talks about lip ties, tongue ties, these buccal ties, and potentially other little webs or tethers throughout the mouth.
Mm-hmm.
So it's in short.
Yeah. And is this something, it seems like we're hearing so much more about tongue ties, lip ties, at least for me. I didn't hear as much about it several years ago. And now we all hear more about tongue ties as people, I guess, become more knowledgeable about what they are and how they can impact short-term health, long-term health, breastfeeding. But is this something new that we're just seeing now, or is this something that has always been around?
Well, as a midwife, I was told that the really tight anterior ties that were found at birth used to be taken care of by a traditional midwife, home birth attendant, who just used a fingernail, kept one fingernail long, and would just clip that really quickly and not even say anything to the parents. So it was something that wasn't, she'd look at the baby, say, "Oh, this is in the way," take care of it, and nobody knew the difference. There are a lot of people talking about how it's because more babies are breastfeeding now. So we had a few generations of mostly bottle-fed babies, and bottle-fed babies usually do better as far as function on the bottle. Not always, but if there's tethered oral tissues, usually a baby can bottle feed better than breastfeed. So perhaps we were missing those generations of babies that really were tethered, but it didn't matter at that point. And then the other theory that goes around is that it's an epigenetic change that's happening because it does seem to be exponentially increasing in the last probably decade or so.
Right. Yeah, that's what I was wondering, if there's something else that might be happening to increase the prevalence. What is the prevalence that that you think of tongue lip ties? Is that an answer that we can give?
Controversial, right, Scott?
Yeah, depends on who
Nancy,
you
do you have
ask.
any
and
idea
what
about that?
literature you're
I don't know. I can tell you in our practice, we see them daily. So for us, it seems like it has grown, as you were saying, exponentially over the last decade. It definitely has become a source of, problematic feeding for these children. And moving forward beyond that, the misdiagnosis of it is becoming a huge problem. We're seeing more and more of these children with alternative methods of feeding because they can't breastfeed or because they can't get to a bottle and be successful with it. So yes, we are seeing an increase, and I'm not quite sure if they're just getting to us because we're more vocal and we verbalize more about the issue, or is it because, this is really becoming so problematic and the public and the moms are becoming more educated and really seeking us out.
Right. Absolutely. Absolutely. That we're going to talk about it a little bit later in the show, the idea of, misdiagnosis, underdiagnosis, and a little bit of resistance from maybe the medical community that might not be as eager to say, yes, this exists, this is here, this is an issue, it needs to be handled sooner rather than later. And we'll talk a little bit about that. But there's also the idea of, some overdiagnosis when we're talking about social media and people just sort of making their own diagnoses or working within just Facebook groups and moms just, taking pictures and sending them out. Does that seem to be an issue as well?
Yes.
absolutely.
Yes.
You're seeing that.
I'd love to talk on that because the fact that it's a diagnosis of form rather than function, almost any child in a picture can look like they have a tie. And those babies that go to providers who may not be educated on the issue and maybe don't get treated as properly as other providers would treat them, that, then it's a failure of, it didn't matter, I got the tongue tie clipped and it didn't do any different, it didn't really help. And that gives the whole procedure and the whole process and the whole field a bad name. Because then we have failures out there and then people saying, well, we did that, it didn't work, or such and such like that. I just want to step back, if you don't mind, and talk about, we mentioned quickly about how we didn't learn about this in school. Yeah. And so I feel badly because a lot of doctors who may not be what we refer to as preferred providers, or they're pediatricians, may be listening tonight, that, we don't want to alienate anybody when we talk about that there's people who don't know about this. They don't know about it because it's not their fault that they don't know about it. Right. And I think that there was a time when I didn't know about it, and I know I missed babies, and I feel terrible about that now, but you can only do what you know at the time. And then the other thing is the resistance to not do anything. People don't want to have to do a procedure for a baby. As a midwife, I grew up non-interventional, least intervention, the better. So I was resistant to have to do a procedure, to have to refer a baby for a procedure. But once I saw that it for some babies, it was the only thing, it was a piece of the puzzle that was missing in lactation care, it changed my mind about that. So I just wanted to get that out there because there's a lot of IBCLCs who don't really have the background that we have now. There's a lot of doctors who haven't learned about it. And it's important not only for the doctors to know, but for the lay public to know, moms and dads going to their pediatrician, that their pediatrician may not have learned about this, and it's not really their fault. It's not for them to be blamed about it.
Such a good point, because none of this we're not doing any of this to blame or to put anybody down. This is all about learning and education. And I love seeing that there are dentists on here, pediatric dentists, there are pediatricians on here, there are nurses and IBCLCs from all over. I see them all here in the chat, and I really honor them for coming to say, yeah, I want to know more, just like we all did, where we, like I'm doing right now. So you're right. It's nobody's fault. This is about just knowledge knowledge and awareness. So great. And then you can spread it and keep learning. You know, we're going to be doing more. And so this is not the end. 2 hours is definitely not enough. I can promise you, definitely not enough to discuss this topic in depth. This is sort of your overview tonight and get to meet everybody. And then we'll be announcing and talking about some really great stuff that we're going to do to really go a little further in depth with the information. So we'll let you all know about that. As far as hereditary, do you think that it runs in families? Do you see that? Like if a mom, do babies typically, if the parents have a tongue tie or a sibling, does that tend to happen?
I've seen a lot of correlation in my practice. Yeah.
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 Okay. So it's something that I guess the moms could be aware of if the first child had an issue, to at least be aware to look for it and have the baby assessed. Where we see this, and you brought up before, Lisa, that it's not, you know, typically they do better. Breastfeeding is where the challenge usually starts. It's not where it ends, but it's the first place that we see it. And so it's very linked to breastfeeding in that way, because it's where we first start to see that there's some kind of a problem. Can you talk a little bit more about that? You know, I know that is really, you're kind of the beginning of the line where you're the one who's like seeing someone for an issue, whether a breastfeeding issue, and then the process starts. So
well, most moms that come to me are coming to me thinking that they have a problem, they're doing something wrong, or it's something to do with their anatomy. And when I do, as a lactation consultant, we examine the mother, the baby, and the feeding. So I consider us to have 3 sets of exams. So usually moms are blamed for things like having flat nipples or having breasts that are the wrong shape or whatever, lots of things. But often it's the baby's anatomy that's the causing the difficulty. So that's where it starts. But what's really interesting, going back to the families, so a lot of times I see second-time moms. So a lot of times moms, first time around, try to breastfeed, things don't go exactly right, and they give up faster than the second time. I get a lot of second-time moms that are like really determined, like this time I'm going to find a lactation consultant and I'm going to get this. Mm-hmm. And when we discuss what happened the first time around, and I say, you know what, bring your toddler next time, let me take a look in his or her mouth, and that baby is tied. And seeing that in the family, and it puts kind of like the pieces of the puzzle together for the mother, because maybe now that toddler is having difficulty with speech or had trouble eating, or at least it gets rid of that guilt about blaming herself for the breastfeeding not working, and it makes sense to her. So it's a big piece of the puzzle. So when I see a family for breastfeeding, I try, I do the evaluations, we work on milk supply, we work on positioning, and it's not an automatic, okay, let me send you to get revised. It's usually, well, what can we do to optimize things before that? And we try everything, because I don't want people, there's a lot of people out there on the internet thinking that, the only answer is find somebody to clip the tie, and it's often not the only answer, which our other practitioners, Jackie Hines is the person I refer to for craniosacral therapy. She works wonders on the babies. And often, even when they're going to need revision, we find there's better results after the baby has had some body work, and the mom's increased her milk supply, and the mother's nipples are healed. It's 3-dimensional. It's not just about, sending them to Scott.
And it's so important, the point you're making, as an IBCLC, we really need to be the one to be managing and making sure that everything's getting evaluated and handled, and they're going to the right people. So if you're having issues with breastfeeding, and typically the 2 issues that I see are pain or low supply. Those are 2 of the reasons that people come in for problems. And both of these things are linked back to this. And so if we are dealing with it, we need to be able to refer to the right person. We need to be able to evaluate it. And then, like you said, now deal with the possibility that the supply really is low as a result of having that tie. So, maybe there wasn't a low supply, and it was caused as a secondary result of it. So, there's still work that needs to be done there. What are some of the besides just pain? Because I know that some people will say, well, it doesn't hurt. And there's, and my milk supply's fine. The baby's just, a couple weeks old. My milk supply's fine. So do I really need to do anything about it? What are some of the other signs that we would be looking for that may not be as obvious as pain, where you're, excruciating pain or no supply?
One of the signs that is often overlooked is the baby who is very, quote unquote, gassy. So, and that may mean the baby that cries a lot because they're taking in a lot of air and their upper bellies are gassy. They may be spitting up a lot, but often, and not to get graphic, very explosive.
Yes.
And foul-smelling bowel movements are often accompany this. And people don't associate that with what's going on in the baby's mouth, but it often is directly tied, no pun intended, linked to that. And, babies that are inconsolable, babies that feed all day long and never seem full because they're having trouble transferring milk. So they're sucking, most babies do suck, swallow, suck, swallow. These babies are suck, swallow. So they're working hard. I talk about it's equivalent to us maybe eating on a treadmill. They're burning calories as they're eating. They're wearing themselves out. They fall asleep. Mom puts them down thinking that she's finished. And 5 minutes later, the baby wakes up and realizes he didn't eat. He's hungry again. And the whole process starts all over again. Right. So very, very long feedings with the baby never being satisfied is one of the first signs in the beginning.
And the gassiness is because of the latch?
It's because when a baby can't lift their tongue properly and move their tongue and get a good seal with the lips, there's air is taken in. So the air goes into the belly, it gets swallowed, and the excess air causes the gas.
Yep.
And that could be effective in the upper or lower GI system.
And Shari, just from like a bodywork manual therapy sort of OTPT perspective, the effect of tethered oral tissues on posture and movement and, all the social skills and play skills and sort of tummy time skills is really apparent as well.
So I'll add to what Michelle is saying, oftentimes the babies that have lip and tongue ties also come in with torticollis, tightness on one side of the neck. Their posture and position is kind of like this, and they can't turn this way. Their neck just won't go. And you'll find the chin is recessed because it's getting pulled back by the tongue, and, the hyoid, which is here, is kind of choking the baby, so all of that's going to play into things and what you're seeing. And you can get compression at the base of the neck here, where you're getting, the vagus nerve exiting, and that's innervating, amongst other things, the GI tract. So you're getting compression there, which could also play into what looks like a reflux.
Right. For us, we find that we will typically see the kids that are beginning to lose weight, failure to thrive. That's one of the first reasons they seek us out. The pediatricians will refer because they're afraid that there's something neuromuscularly going on that we need to address. And then when we evaluate, we see that this tie is essentially what is preventing them from transferring the milk, gaining weight.
Yeah. Wow. It's amazing as you're just describing it, how much the tongue really and the muscles of the mouth, how everything is so connected, and how much you can really see that throughout the whole body, not just in the diagnosis and what you'll see in symptoms, but also in the treatment of how important that is to incorporate all of this into the treatment as well. So it makes so much sense as you're describing.
Well, that's why I started using the term cranial nerve dysfunction, because we see these issues trailing over into airway, digestion, autonomic nervous system regulation, and how we orient our posture in space. And it trickles down into the whole body system, How we're doing in the mouth is reflected, especially in babies.
Mm-hmm. Yeah. I guess that if for babies that maybe are not breastfeeding, this is a great place for them to be looking to see if there's any issues with that, to think of this, because they may be not having those same feeding issues that a breast not, but this may be what they're seeing.
Yes.
Mm-hmm. Great.
The other thing I'm not sure if anybody mentioned was also looking at sleep posture. Is this a baby that has to sleep with their head in extension, back like this, with their mouth open? Because that's really opening the airway. So sometimes babies will posture that way, and that's really for airway protection. So it's another really crucial thing to look for because that's breathing. It's important.
Yeah, a little important. For sure.
We also see babies that have a really, really hard time with being in the car seat. And that seems to be something that's related. I don't know, you body workers on the team can explain that a little bit better than me, but that's definitely correlated, and also having trouble in tummy time. So the tummy time is definitely connected.
That was actually one of the questions that someone posted about, will there be, she wants to know how a lip or tongue tie may affect how the baby feels in a stroller or car seat. So that came in from Anna. So is there anybody who can answer that a little bit?
Well, I'll start. Maybe Jack. Go ahead, Jack. You go first.
Sorry. I was just going to say, sometimes if you look, here's a baby skull. So if you look, here's your jaw, right? So we're talking about tethered oral tissue. So we're talking about here and we're talking about here, right? However, if you see where the jaw is, it's
hold
going
to hold it up a little higher. There you go.
Is that better?
Yep.
Here's your jaw, and that's going to articulate with the cranium, right? So you have the temporal bones here. So temporal bones translating on our heads is kind of above our ear. So sometimes when you have, I said about the chin being retracted, so that's going to look like that. If you look at the baby from the side, from the thighs, the chin's going to be pulled back. So if I move my finger, sorry, you're going to see that changed the alignment at that temporal mandibular joint, right? So that could impact, your ears are here, right? That can impact the fluid balance and the way that the canal in the ear is, which can impact the vestibular system. So that sometimes, I think, is a reason why these babies have trouble or more trouble in car seats and in strollers and in restricted posture, because maybe that's not the posture that feels right for them or feels balanced for them inside of their bodies. And also, as I mentioned about the posture, you get this baby here, and then they're in the car seat and they're like this, they're so tight in the head and the neck and the shoulders, that's not comfortable. So I think that's kind of what I see, and Michelle, I'm sure, can add to that.
I think that was very well said. Perfect. Thank you. That's what I would say.
We have agreement. That's good. It's good.
I just want to add to Jackie's and Michelle's positioning. I think more often than not, we're seeing a lot of physicians who are misinterpreting that posturing that you're seeing because they're trying to keep a patent airway. They begin to cry and they're being misdiagnosed with Sandifer syndrome. So that then propels them on, a trajectory of using all of these reflux medications to manage something when it could sincerely just be positional and things that we need to do to rectify this tether.
Mm-hmm.
That's all.
I agree with you. The overuse of reflux medication is a tough one.
Mm-hmm. Huge. And so much more. As you said earlier, Lisa, over the last decade, we've just seen more and more and more of that. And at the same time, starting to see more and more tongue tie diagnosis. So it really does go together, but we do see a lot of that medication. Probably most of it unnecessary. But, again, it's one of those things where when that's the only thing you can really think of to offer, it may be, that's it. So I want to just talk a little bit about what about the different classes of tongue ties, and maybe Scott can talk about this. Because we hear about, I know the moms out there and everyone is thinking, well, I don't see it, what's a posterior tie? I hear about all these different things. What does this all mean?
Right. I mean, basically there are different classification systems out there, that some are very commonly used, and some of them just really kind of go based on anatomic position. We can even pull up a slide here. Let's see. We can just do two simple slides. We can do number 57 and number 58 just to kind of give a little illustration.
Okay, give me 1 second here. 57 and 58, you said?
Right. So, you know,
Hold on. 57, there we go. Okay, yeah.
when people think of tongue ties, or many pediatricians think about tongue ties or ties in general, they're usually thinking about something very obvious in their minds. And I know that's, you know, when I went through medical school and dental school, that's kind of the only thing I was taught, maybe one slide that looked like this, where you see this little thin membrane attaching the tongue, or the tip of the tongue, or something, you know, that's very obvious to see. So in simple terms, and I try to keep things fairly simple without getting into all the craziness of the classification systems, I generally talk about anterior versus posterior. And anterior is usually the thin little web that most people can see. Many times you can see it from across the room. In this slide, you can see it right in between the Q-tips, that little web. And if you go to the next slide, you know, this is a little less obvious. So as you start to, if you just let this tongue go or relax, you really wouldn't see much there. And it's more, we're always going based on the function, but we're also looking at the form here too. So when you're looking in between the Q-tips, there's more of a thicker, broader band here, which we kind of term posterior. And basically, they don't really have anything to do with severity, although there's, you know, some issues with maybe potential severity of tongue ties here, but it's more or less just a general classification system. People are always throwing the terms anterior versus posterior around, and it's very confusing. It was very confusing to me when I first learned about it 20 years ago. When Betty Carrillos was telling you posterior tongue tie, I was thinking something in the way back of the tongue, close to the throat, because that's where you think of the back of the tongue, or posterior tongue. So when we talk to ENTs or pediatricians about these things, I think, you know, there really needs to be a clarification about what we are actually talking about. And I know when I educate pediatricians and residents about these things, we try to keep it in very simple terms. And if you go to slide 56, there's a good schematic about this. And this Bobby Gahary had put up on one of his social media blogs a few years ago, really kind of driving home, you know, the concept here. And this graphic, the illustration of the sailboat with the mast. And the mast is really kind of what we consider the posterior aspect of the posterior tongue tie. And the anterior aspect is that sail, which is that thin little membrane. Now, one of the things that's really important about when we use these classification systems is understanding that all of these anterior ties have this posterior component. And when we're teaching people how to actually do full surgical releases, it's really an important concept to understand that that mast, or that posterior component, still needs to be released. And we find a lot of doctors who are, you know, saying, oh, I see a tongue tie. They just go to release that little thin web or that sail. They don't get behind it or further back, and they don't get a full release. And invariably what tends to happen is we'll find that many of the moms, you know, get minimal success or minimal improvements. And that's when we start talking about failures. So we talk about failures, you know, in diagnosis. We talk about failures in preoperative treatment. We talk about failures in operative treatment, and then post-operative. So, you know, I don't want to get too bogged down in classification systems here, but just kind of keep it brief. I think this kind of hits it home.
That's great. No, I think having the diagram to see that illustration, I have a few people in the chat room were saying, my child's tongue looks like that. My baby's tongue looks like that. And that just kind of leads into, you know, so they see something, maybe they're not having issues. Who would they actually go to have that evaluated? I mean, like, who actually needs to make the diagnosis on this?
Well, that's controversial to me. You know, I'm going to just talk briefly here because I consider myself the middleman here. Yeah. I depend on IBCLCs diagnosing babies. And I know technically you're not supposed to diagnose, but I depend on it. And, you know, I can see the babies, I can do my assessments, and at this point, I'm experienced enough to kind of figure it out, but I still have trouble. And So when I'm talking about an infant, a breastfeeding infant, I'm really depending on the IBCLC. If I'm talking about, some of the babies that Nancy's seeing that are dealing with other feeding issues or whatnot, she's the one I depend on. Sometimes I'm getting them from pediatricians, but really the gatekeeper for the infant is traditionally the IBCLC, and it's really, lactation specialist. And then we work as a team, and we'll talk more about that team approach with the body workers and the other specialists. But I'll let the rest of everybody chime in.
Once it's actually determined that there is a problem, that there is a tie, that there's something needs to be done, what's the next step? Is there a prep that needs to be done before that? Do you usually refer for body work before the procedure, or is that something that's done after? And then let's talk about the whole process here of what actually does happen.
Shari, I'll take that. Oh, sorry, Scott. It really is individual because it depends on the age of the baby, what's going on. So if I have a newborn that can't eat, I'm not going to wait for body work for that baby. If I have a newborn that can't open his mouth enough to, have a latch and transfer milk, and everything else seems to, assesses that it's okay, then I'm going to refer that baby to go, see Dr. Siegel as soon as possible. If the baby's a few weeks old and it's eating, but mom's having a little discomfort, but her milk supply is a little lagging, and the baby's got some tightness, then I'll refer for body work first before we see Dr. Siegel. And some of the prep that isn't, besides just having, evaluation by a body worker, and I refer also to a chiropractor. I like to give parents options. Chiropractor or the craniosacral therapist. There's also an occupational therapist locally that I refer to for tummy time method, who Michelle actually trains. So I have one of her students in our area, occupational therapy. And then I teach some exercises to get the tongue moving, so that the parents will know what to do after, realizing that the tongue needs therapy after, like physical therapy of the actual tongue after the procedure. So I want to let parents know what to do afterwards. After they have the procedure, there's going to be exercises so the baby gets used to the parents putting their fingers in their mouth and getting used to having their tongue played with a little bit. And then we talk about, depending on the age of the baby, what are we going to do for pain relief for this baby? Because depending on the age, it could be something that's an issue. So we talk about different methods of analgesia depending on the age of the baby. And, Scott did mention, the little controversy about assessing, diagnosing. You and I are both in an advantage because we are licensed midwives. We can diagnose. But a lot of the IBCLCs are, by their scope of practice, they can't use the word diagnose. They use the word assess. So, but they're doing the same thing. So if there's an IBCLC that's trained in ties, she's just got to watch her language, which is kind of a shame. But it is still the IBCLC who is the one who would know when this is something that the baby needs to be referred for and what to do about it.
Well, it would need to be an IBCLC who has extra training too, because not all IBCLCs have the training. So
that's a good point, Michelle.
Yeah, absolutely. A
lot of the hospital IBCLCs either don't have training or are prevented from speaking about this in the hospital. I do see a lot of hospitals now are getting a little bit more progressive in looking for what they think they're looking for, and there may not be somebody trained on staff to do the release properly. So we have some babies that'll come to us and say that, oh yeah, my baby had a tongue tie. The pediatrician found it in the hospital and they clipped it, but she's still having problems because it wasn't a complete release. So I don't want to diss all hospital doctors. I don't mean to do that, but that's, in my experience, that's what I've been seeing lately.
Right. And the risk of, when parents and babies are treated in the hospital and then they run into problems later, is that they think they've already had the treatment, and that's not always the truth. And so I am an advocate for clipping a little bit in the hospital if that comes up, if it's appropriate, but letting the parent know that that may not be the full thing. That's what I'm advocating in our area, just to let them know that they still need to follow up with that it may not be everything that they need.
Yeah, and just to add to what Michelle is saying, and we talked about the team approach, it's so important that if you have the baby revised and you go in there and you make changes to that tongue, like any other muscle of the body, you have to re-coordinate movement. The baby hasn't moved this tongue in this new movement pattern. And babies are so quick to heal, which I'm sure we'll talk about in the aftercare, but they're so quick to heal that if you do nothing and you think you're doing the right thing because nobody told you to do otherwise, then you're going to have a baby that reattaches, and you're going to have a baby that has difficulty 2 weeks later, even 1 week later, and then you're going to say, this doesn't work. This is wrong. This is everything that you don't want it to be. And for me, I practice very holistically. And like Lisa was saying, you know, all of a sudden you're referring babies to do this surgical procedure. And for me, and I know Michelle does cranial work as well, it's really important also because it releases the trauma. It calms that central nervous system. So here's a baby that's been through trauma. And it's important to calm that baby back down and also to reorganize that patterning and that suck, swallow, and breathe, and getting that tongue to move properly after, because it's not, in most cases, just going to happen. It can just happen, just like things you say, oh, my neighbor had his knee surgery and he didn't go to therapy and he's fine. Well, if you have knee surgery and you don't go to therapy, you may be fine, but you might not be.
Right. Great point. Yeah, I want to talk about the procedure. I want to talk a little bit about that. I also want to ask the audience here, you know, there's so many people on and everybody's posting so many questions and they're really enjoying it. I want to see some hearts going across the screen. If you're loving this conversation, as you can see, we can do this all night. So if we still have some time, we're going to be going through a lot more. If you know anybody who needs to hear this, there's a little share button right there at the bottom of your chat. Go ahead and hit the share and let people know that we're still discussing. We have a lot more that we're going to talk about. And then if you missed any part of it, if you came in late, I see a few people just joining a little late. Don't worry, if you're registered, you'll be able to go and see the replay and watch the entire thing from the beginning. So just wanted to say that. Can we talk about the procedure, Scott?
Sure. I mean, you know, basically the procedure it's a fairly simple surgical procedure. I'm just going to describe it and talk about it. Maybe you can pull up a couple of slides. But, you know, the actual procedure itself, we make a very big to-do out of. You know, from a surgical standpoint, it's a fairly simple procedure, but there's a lot of nuances to it. And I think that's what happens with the procedure. Some people oversimplify it and wind up doing it incompletely. So, it takes a while to kind of learn it and get it, you know, the comfort level there. But the actual procedure itself is, you know, in my hands, it's about a 30 to 45 second procedure to do maybe a couple of ties. If you're talking about lip tie and tongue tie and maybe adding buccal ties, it's usually less than a minute. And it's a very safe, easy procedure. It can be done either with scissors or laser. Now, I'm a laser surgeon, so I talk about lasers, and I talk about, you know, why I think they're superior. And I think if you find the people around the world that are doing the largest volumes of babies, they've transitioned over to lasers over the years. And it's basically, the laser it's not a new instrument. It's been around since the 60s. I've been using lasers for 18 years now in private practice. I used it in my residency as well. Specifically, I use a CO2 or carbon dioxide laser. And it's a very safe, easy way to do the procedure. Basically, the nice thing about a laser is it cauterizes as it cuts, so you don't really get much bleeding. Now, if you want to just talk about, you know, diagnosis or what it might look like when you're bringing a baby into the office or whatnot, we can just go over a couple of quick slides, like number 62.
Mm-hmm.
Yeah, go through 62 to 60 something. We can scroll through. But when we talk about diagnosis, you know, and at the time of the, you know, when you're seeing a surgeon, there are certain questions that you can ask about, you know, the procedure itself. Is really the things you want to know from the doctor who you're seeing is really how do they assess, how many do they do, how many do they do a week or per month. You want to kind of get an idea of the volume that they're seeing and making sure that they have a, you know, an understanding of the nuances involved here. And basically, you know, what we talk about, yeah, it's a simple procedure. And again, I consider myself the middleman here. I want these babies coming to me with a functional assessment and a plan. That's not always reality, and in a large part, it's not reality, but we try to do our best. But you'll see, you know, there's a lot of social media out there. There's a lot of blogs. There's no one right way to do things, and a lot of it just becomes a comfort level of the practitioner. One of the instruments I like to use for my assessment is that little Mickey Mouse little looking instrument there called the Groove Director, which is a nice way to kind of lift up the tongue. It's also a nice instrument when we're doing the actual release that people always ask, well, how are you going to hold the tongue? You know, and holding a baby still is a very key issue. It's a very key thing. So, you know, it takes a lot of practice. Your staff has to be really trained in understanding how to do this as well. So those are questions you want to really ask, you know, the practitioner. I think most practitioners will find it easier to come from behind the baby or relatively either on the side or from behind versus coming from the front. So I think if you're at a pediatrician's office or another practitioner's office and they're trying to do something from the front, you might want to double check. And I'm not going to just say, yeah, this is the only way to do it, but it usually you'll get much more improved visibility. So usually you want to either swaddle the baby or make sure that they have all their limbs restrained. And I don't know, I'm not going to get too involved in the actual treatment.
Yeah.
But if you go to slide 69, it kind of shows you what a laser is. There's different types of lasers out there. I specifically use, you know, this laser here called the light scalpel, which is a wonderful laser that a lot of tongue-tied docs in the United States use at this point. There are other lasers out there that are very good as well. But we talk about the term laser, and a lot of people get this in their mind that it's like a lightsaber, like it's this instrument that's slicing through everything. What happens if you slip? Are you going to slice through the cheek and the laser beam's going to come out all over the place? And what I always tell, and I usually will demonstrate to them as well, it's a very delicate instrument. And when you actually step on a little pedal, you can control exactly, you know, when it's on, when it's off, and you can actually control how deep the laser is cutting. So it's actually a very delicate instrument, and it only takes cell layers off at a time, or very, very shallow depths. So you can actually see things as you are cutting them kind of just fade away or melt away in front of your eyes, or if you want to be technical, vaporize, and you can actually see exactly what you're cutting and get to what we call a great endpoint. And you know, it's been a superior way in my mind, or my experience of treating these babies. Maybe we go to 74.
Mm-hmm. 1 second, I keep losing the share here. Hold on. Mm-hmm.
So, you know, it basically shows all the babies should have, if you're doing it with laser, and I'm not saying everybody has to do it that way, but this is the way I do it. I talk about the sandwich model. Again, we go from, you know, preoperative therapy, which is lactation insulting, whatever work that needs to be done beforehand, doing the surgery, and then the follow-up, suck training and body work. And this is talking about breastfeeding children. We talk about older children as well, which we're not talking about here tonight, but we talk a lot about speech. We talk about airway, other functional issues. But this whole sandwich, quote unquote, sandwich model is really, you know, in my mind, and I think, you know, this team approach here has really been the way to get the best success. Mm-hmm. I don't know if I'm not going to show a video because I don't want to get anybody grossed out here, but just to know that a very fast, easy procedure. Maybe we can show. Let me see if I have any before and afters that are not too gory looking, of just, even older people. Let me see here. I guess maybe slide 93 is always just a good, quick little. This doesn't show so clearly, but this is a pretty obvious tie on the left, and this is immediately, post surgery, which you'll see is. I don't know if you can see my arrow, but this is usually like a little diamond-shaped open wound that's usually not bleeding, and then to the right is as it's healing. So that kind of shows it a little bit. But let me. You want to go to slide 81 and 82, which shows an adult, but it can kind of show you what a wound looks like immediately after the surgery with a laser, just to get an idea. So that's, it's a pretty classic lip tie in an adult. And the next, which is basically kind of like what we consider like a cauterized wound. There's really not much bleeding. This is immediately after the surgery. So if I did this with a scissor, it's typically a very big bloody mess. Mm-hmm. And first trained to do it in babies and doing complete releases, I was trained with scissors. And to do it fully and do a full release, it was a little bit scary sometimes, handing a very, bloody baby back to mom. Although the bleeding stops very quickly, I think those of us who are doing the most out there in the United States anyway are mostly doing lasers. So right. That's my bias at this point.
Everybody in the chat is saying video, please.
Yeah.
All right, let's see.
They all want to be grossed out, Scott.
All right, let's see if we can.
Let's see if we can do it on here. I'm not sure.
Try number 90.
Because you know what? I think this is not in PowerPoint here. This is in. Okay. Yeah, I don't think I can show the video. We're gonna have to show.
I'll have to put links up to it.
What?
Maybe we can put links up to it afterwards.
We can put links, definitely put links, or we can save that for our big event, and we'll be able to do all kinds of audio visuals with that. We can see everybody wants more of that, and we'll be able to make sure that we have all the videos that they need. But yeah, we'll post a link to the video afterwards. Yeah, so there were a couple questions that were starting to come in. Just I'm noticing here, like people were asking, can there be a lip tie without a tongue tie?
You're asking me?
I almost never see that.
Mm-hmm.
Almost never. I won't say never, but almost never.
I admin a fairly large parent support group, the tongue tie, lip tie baby support group, and I posted that there's very, very rarely a lip tie without a tongue tie, because that's my experience as well, and that's also what other people and you found. And I got a lot of feedback that there is, in fact, lip ties without tongue ties. So that, I think, I was really amazed at the feedback that I got, at how many babies have been diagnosed with a lip tie without a tongue tie. Now, whether that was accurate diagnosis or not is the question, but I was surprised by the response.
Mm-hmm.
So I think we have a gap to fill here with education about proper identification, and when we do find the lip, and how we look at the tongue, and the tongue still being the biggest piece of the tethered oral tissues, and it being the primary focus. And the other tethers are, important as well, but the tongue being the most important. So I think we do have a little bit of a bridge here with the educational piece.
Right. There was also another question. Were you going to say something? I'm sorry.
No, I agree.
Yeah. Another question came in. Abby in the chat was asking Nancy, could you explain how an SLP could assess for a posterior tongue tie?
That's kind of a loaded question, but so in a typical oral motor or oral mechanism, peripheral oral exam, whatever you want to call it, I learned differently than what most SLPs are being taught. I'm going to digress a little bit and then catch back up. But of late, there's been a lot of controversy about oral motor, oral musculature, and whether or not there should be exercises surrounding that. I will give credit to that if we're talking about speech, but in feeding, it is critical that there are oral motor exercises involved. So when we do an oral mechanism evaluation, we look for function for everything: the lips, the tongue, the cheeks, how the swallow is being coordinated, how the sucking is being coordinated. What I find the easiest, and it depends on the age, is that we check for that suck. We do use our finger and go right in on baby and see what that tongue is doing. We're not so worried about the mechanism per se. We're worried about the function. We want to make sure that that function is really controlled and working well. Otherwise, it doesn't matter if all the structures are intact. We can look at any baby and say, yep, they have a tongue, yep, they have lips. But if we get in there and we see that they're not able to actually suck, and you can't feel the rise in that tongue, and you can't feel the compression or that negative pressure and that pull on your finger, then we know something is off. So we want to check first. Are the lips closing around the finger? Are they able to make a good labial seal on that finger? When we press or palpate or turn our finger to stroke that palate, are we able to get that baby to suck? Is it rising to meet our finger? Can we feel it actually functioning? I think it's a simple and easy evaluation process, and I think we miss that a lot when we treat with these younger babies. I'm not so sure that everybody sees this population, but this is at least how we treat or how we test for it.
Mm-hmm. Awesome. Awesome.
Can I just jump in? I just wanted to share that I think it's so interesting listening to the other providers talk. We all have different backgrounds and areas of expertise, yet we're all looking at the same thing.
Right.
So that's why it's so important to have this team approach, because even though we're looking at the same thing, we're going to go about treating it differently.
Right.
And
the perspective is different.
Yeah, and we might do different techniques. Well, I know we do, but our goals are both the same, which is really kind of neat.
Yeah, totally.
Agreed.
Totally.
I hope I answered her question.
I think you did. Everybody's saying, oh, that's, yeah, they were saying they totally agree.
Or they can just ask the question, email me. Hopefully I can show them a video of us at work.
Yeah. Yeah, so anybody who wants to get information about any of the experts that are here and wants to follow them on Facebook, please go do that anyway. But right on the same TOTS page that we created where you all registered, and Joel put the link up again, it's the bit.ly/TOTS panel. You just need to register. If you already did, you'll go right into the content section. And above everybody's bios and pictures, there's a little like button for their Facebook pages, so you can automatically like or share their Facebook pages, follow them there, ask questions, and also there's a link there to learn more, to go to their websites, plus all the downloads that everybody provided so generously. So make sure that you check that out, and if you're not registered, go do that so that we can keep notifying you about any future events that we're going to do. Plus, that is where the replay is going to be. I know I'm going to get a million questions on my Facebook page later going, where's the video? Where's the video? It is going to be by tomorrow morning. You will see it on that page. Okay, so that's how you share it, is you can share that page. All right. Let's move on here to, well, just to finish up on the revision, how quickly after the procedure, I mean, typically babies can go right to breast right after?
Yeah, I have them immediately afterwards. So basically, as soon as we're done, mom scoops up the baby, or we give baby back to mom and get skin to skin immediately afterwards.
Mm-hmm.
You know, I think the skin to skin is, and I'll let everybody else chime in about that, especially Lisa, but you know, it's really an important part of the process, and trying to latch. And again, you know, informing that this is a process. It's not a silver bullet or magic bullet. So we really stress that to the families. There's a lot of hopes and expectations that the procedure is going to be it. Everything's fine. And, you know, it's time and time again, you set yourself up for disappointment that way. But we do try to get immediately on, and then back to, you know, lactation support as soon as possible, and for the body work and, you know, other forms of that as soon as possible in my mind as well.
I can imagine there's a lot of people who come in thinking that is going to be the end all, that they'll have their revision done and then everything should be fine. And then when it's not, or there's work that needs to be done, they're surprised or shocked by it. So I think it's a really good point that needs to be talked about, is that it's not the end of it. And even if you do have, and you guys can all correct me if I'm wrong here, but even if you do feel better, it's important to continue with the aftercare, because you can have the reattachment and or you can have the this tongue's not functioning properly. Right? Even if you're feeling less pain.
Absolutely, Shari. And I do get, I see moms at all different levels and all different circumstances, moms and babies together. And sometimes it'll be a mom whose pediatrician referred, we're lucky that some of the pediatricians in my area are starting to recognize the problem. However, they're not recognizing the importance of IBCLC care or body work, in the teamwork aspect of it. And they'll just send the baby up to Scott and Scott will do his magic, but then it's not all better, and I had the thing done and now what? And, and if they don't come to me in time, sometimes it's healed and we have to start from scratch again. So definitely. And I wanted to just say a little bit to go on after, Scott talks about putting them in, he's got private rooms where the baby can be skin to skin, and skin to skin is talking my language, as you know, Shari. And often the baby does very well at that feeding. That feeding is usually, in my experience, from what I hear, a good feeding. And then later on that night, there's a hiccup, or the next day. So I like to give anticipatory guidance for the first night, and have moms ready with maybe an alternate feeding method, maybe some pumped breast milk just in case. I often talk about, the mom relaxing into it as much as the baby. So maybe mom taking a bath with a little bit of lavender, essential oil in the bath so she can relax, put the baby skin to skin with mom in the bath, because the water helps the baby just reorganize themselves and come to the breast that way. So I think the key, though, is being prepared that evening may be a rough evening, and definitely not to plan anything for the day after or the next day. Try and have it on a day when mom's going to be home for a couple of days. There's no parties planned. There's no big events going on. It's not so-and-so's birthday party the next day that you have to go to. Just hanging out and chilling with the baby and relaxing and healing together. Yeah, is something I recommend.
I'd like to jump in real quick, because we've all talked about mom, but we failed to mention the importance of dad or the partner in the situation, if there is someone or whatever support system you have in the home for that baby, because it's more than just the mom and the baby. Because like Lisa said, trying to keep mom calm, but you know what? Sometimes mom needs a little bit of help. And, it's important to keep that in mind as the partner, as the dad, as the grandma, grandpa support system, that you're really helping care for mom too, because it's trauma for that couple, that mom and baby. It's traumatic, and it's so important for us to be mindful of that, because mom and baby share an energetic field. So if mom's nervous system is super elevated, the baby's is going to be super elevated. If mom can come down a bit, baby will come down a bit. So I see that a lot. And like Lisa said, that first night is a tough one. So it is important to prepare our families for that.
Such a great point. And so often we do just talk about mom and baby. And, dads are right there, like you said, feeling everything. It's their baby too, going through a procedure and supporting their wives. And we had a show last week about baby blues and postpartum depression, and even then how much we talk about mom, and yes, moms are going through so much, and then there's also dad too. And so I thank you for bringing that up, Jackie, because I know that there's also dads watching. Usually it's the dads watching in the background hearing my voice over and over again going, who is that? But we do have some dads here in this chat as well. So, and we have Joe too. So
this is a family event. It's a family affair when the babies come in or they're having difficulty feeding. Many people don't realize heightened anxiety levels that have been going on, and that's where I think there's a big failure to see and even to screen out if a mom's dealing with a postpartum, anxiety or depression or something like that, which is really, it's difficult to deal with, and sometimes it doesn't get unsurfaced until, unfortunately, after we do a surgical procedure, and then you realize that we uncovered something here, it's more than just a tie. So I think that's another, that's a whole nother seminar, but it's something that I think we really all have to pay attention to, because I see it a lot. I know other practitioners do, and that really influences our success rates significantly.
Yeah.
And from my standpoint as a surgeon, in general, my patients get my personal contact number, but these families get my cell phone, and they're texting 24/7. So I think that's an important part for the continuity and hand holding that goes on. And I think a lot of some practitioners don't understand that, and they kind of just do the procedure and then send the families on their way, and then they're all of a sudden alone if they don't have the lactation support, because geographically sometimes they just can't have it. They need those hands to hold, and I think that's a really important part of the team.
So important. And I think that's where, like you said, having that IBCLC to reach out to someone who is, and then of course someone who's knowledgeable in tongue and lip ties, and I guess even just having support, even if that person may not have the ultimate experience in tongue and lip ties, but knows how to refer you to someone who can support you. They can still be there to support you with with latch, with milk supply, with everything else that is needed. So we're not looking for perfection. We're looking for support.
Absolutely, Shari. I think that just to have somebody to discuss what's going on, bounce your feelings off of. Often part of my job is not very technical. It's just listening and holding space for the family, and letting them know that what they're going through is normal or expected. I don't really like the word normal, but that it's expected, and it happens, and it's okay, and validating their feelings and their fears and things like that. And the follow-up though is so important, and the way we have it worked out is I usually see the babies that are done that Dr. Siegel sees about 3 or 4 days after, just to make sure that, do a physical assessment, make sure that the mom is adjusting latch-wise with the baby, examining the baby's mouth and making sure there's not reattachment. We haven't started talking about aftercare yet, but a lot of times what is taught in the office that first day, parents are just too overwhelmed to understand. So I like to teach it before, but even that doesn't always translate, because emotionally going through that procedure, you get a little bit of amnesia, I think. And then getting together with the family 2 or 3 days later to reinforce everything and to demonstrate things again really does seem to be beneficial. And I think that since we've been doing that, we're having better results. I think you'd agree with that, right, Scott?
Yeah, absolutely.
Really great.
And then those babies that, if I sent them straight away to Scott because it was an urgent procedure, because the baby was having that much difficulty, that's when I have the discussion about body work. Or I'll say, remember we talked about body work? Well, now this is what you need to do. And depending on what I see in the baby, depending on where the issues lie, maybe where which body work or which part of the team I refer to at that point. Whether it be chiropractic or CST. I mean, I'd love every baby to see every practitioner, but that's really not realistic.
Yeah.
Well, I have a question for Jackie. Sorry, Jackie. And this is a professional question, and I'm sure others, may not know exactly what CST is, but I'm not trying to convince my patients to see you, but I need a good I guess, narrative for me to be like, this is why it will help you. Being a speech pathologist, we don't have much interaction with craniosacral therapists other than this format that, you know, this panel and you and I knowing each other. But I think it would be important for all the other SLPs that may be listening, the moms, the lactation consultants, to know at what point do we begin speaking and what do we say to them so they understand that this is critical.
Yeah, absolutely. It's a great question because a lot of people don't know what craniosacral is. So how do you know you need something if you don't know what it is? Right. So it's really a good question. So craniosacral, I'll get my little guys. Cranium. It's your sacrum, right? So in between is where your spinal cord is. So you have what's called cerebrospinal fluid, and that goes up the dural tube. So it's going up this tube, circulating the membranes of the brain and coming back down. As that happens, it creates a rhythm. So that rhythm can be palpated throughout the body, just like your heartbeat is palpated throughout the body. So one of the things I'll look for is, what does that rhythm feel like? But I'm also looking at tissue, at bony alignment, at the fascia, muscular pull, kind of what does the body feel like? That's kind of the easiest way to say it. What am I feeling in the body? And then what I do is I'm kind of following that body, those restriction and tension patterns. So let's say, like I talked before, I have this baby who comes in, whose jaw is recessed, right? And then they're tight on one side of the neck. So what starts to happen, what I start to see, so the cranial bones are not fused. You can see there's these suture lines. So some babies, when you feel their heads, like you go back like this, you'll feel at these suture lines that there's actually ridging and bumps. You'll see when you look at the forehead that there's actually bulging or bossing. So one side, because the baby's postured like this, they're compressing the back of the head. So they're compressing at the parietal bone, at the occiput, they're compressing this. So it's pushing here at this suture line, causing a bulge. This side of the forehead comes forward. So sometimes you're seeing those actual cranial asymmetries. You could see other asymmetries, but from a cranial perspective alone, you start to see that. You're getting this chin recessed because of the ties, right, pulling things back. You have this tongue that's attaching, you know, under here, and it's pulling this back. You have the vomer that you would get to, kind of coming to the top of the palate, that sometimes is up and compressed into the cranium. So you have a high palate because the tongue isn't able to come up, as you know, from a speech perspective, you probably know better than me, but your tongue is not coming up to the palate. So it's not widening the palate, as you know. So now we have a high, narrow palate, and then we have a tongue not coming up. How is that vomer going to come down? And also, as you breastfeed, as that tongue is coming up, what one of the functions of the tongue is, and having these, you know, fontanelles, and that cerebrospinal fluid flowing properly, blood flow coming properly, is you're going to get, if you had cranial bone overriding, so at birth, as the head comes out, these bones are supposed to override to allow the head to kind of compress a bit to come out. Now, if you're not sucking properly, they're not necessarily going to decompress. So at these suture lines, you might have those bones riding on top of one another. So working to kind of decompress that. So underneath the cranial bones, you have the cranial membranes. So that's why it's super important that you decompress things, because you have the cranial membranes underneath. And then you also have all the cranial nerves. So Michelle was mentioning before, which I'll let her kind of talk right after, about cranial nerve compression. But if you have compression of the cranial nerves as they're going through different structures, you're going to see dysfunction. You could see it in the ears, you could see it in the mouth, you could see it in the eyes. So all of these things are things that I kind of look for. Also at the sacrum. So sometimes babies, you know, will have tension at the head and neck, but what do they feel like? So the sacrum, this is your tailbone. I'm just raising it higher so you can see it. It's kind of the end where you're sitting. So this might be shifted. It might be shifted this way. It might be shifted this way, this way. There's just this tension pattern in the body that we need to release. We need to realign things so that the central nervous system, brain, spinal cord, all the spinal nerves and the cranial nerves can function properly. So in order to have all of our systems functioning correctly, we need our nervous system to be functioning correctly. So if there's restrictions anywhere in that system, you're going to find dysfunction typically. You know, you might not see it right away, but you'll see it later in development. Maybe the baby can't crawl. but we're looking at these babies at such a young age. We might see also babies who, at birth, they can hold their head up. Well, that's not a good thing. You might see these babies at birth or 10 days old that are rolling over. My own son did that, so I get it. But what it is that he had such a tension restriction pattern that was pulling his body. So we need to release those tight muscles and those, restrictions in order to align the body for function and development and optimal feeding. Because if you're not aligned and the hyoid's compressed, this is twisted, your jaw's twisted, you're not going to be able to really do feeding. So that's kind of where, for me, as a physical therapist, and having that background combined with the cranial work, it's really, for me, I look at the whole body. What am I seeing? What's going on developmentally? What's going on positionally? Where is the baby throughout the day? Because that's really important too for me. So you can do the best work on a baby, but if they're going home and spending 12 hours sleeping in a rock and play, for example, sorry, Fisher Price. But if babies are sleeping in those, you're going to end up, in this position where you're stuck for 12 hours, and then you're going to feed into those restriction patterns. So from a cranial perspective, it's important to fully release. So, what does it look like? What does it feel like? The amount of pressure that's used in craniosacral therapy is the weight of a nickel. So if you put a nickel on your arm, that's how much weight is used. There's nothing fast, there's nothing abrupt, it's very gentle. It's kind of the idea that you want to go into the body undetected so the body's not fighting back. So I give kind of the polar opposite. The polar opposite would be a trigger point release massage, which is fantastic, and I love that. The cranial work is the opposite, So if you're getting somebody on that trigger point and they're pushing, you kind of like it, but it really hurts, but you want to relax, but you can't. This is the opposite. You're kind of sneaking into the body, blending and melding to make changes. I'm not sure if that makes sense, but that's kind of.
No, absolutely.
Yeah. Did I answer everything?
That's a great explanation. It's a little bit hard for parents to maybe wrap their mind around some of that, but if you can just pull little pieces in to make it sound like, we heard a lot about tension patterns and positioning and being limited. And a lot of times when I describe it too, just like Jackie's saying, is more about relaxing and moving and really helping the nervous system regulate and help the baby and the mom feel safe enough to take a risk to do something new, and use some of these words too, like relaxation. That really helps a lot to help us understand all of these things.
Great, thank you.
You're welcome.
That was great. That was really great. Maybe could you elaborate a little bit more, Michelle? Maybe go into a little bit of what kind of aftercare you provide with after the procedures and when you're working with these babies.
Okay, I'd love to talk about aftercare, but before I do that, I'd love to talk about what we do before the release, if possible.
Go ahead, absolutely.
And, I really like how Lisa was mentioning about making decisions, and the timing of release based on the individual baby and the symptoms that they're presenting with and the situation that we're up against. And for me too, in addition to that, it's about looking at how their movement function is already happening, their cranial nerve integration and function, and how their oral mechanism and their jaw is working before we even know when we're going to go in. Because if the baby is not moving well and not moving at all, it's really hard to understand how just releasing the connective tissue is going to do anything. So I like to work before, but yes, let me go and talk about the aftercare. And where I'm at in Cincinnati, we work in a team approach. We like our IBCLC to see the baby the day after, and then I see the baby the day after that. And we start, I do lifts and visualizations, and I also do a lot of active tongue movement, and my main modality is the tummy time method. So it's a comprehensive way of getting a baby really to like the position and be comfortable in their body, and also to work on all the complicated neck, shoulder, head, and tongue muscles. So we then follow up. We have the parents doing stuff every day, and it's a 2 to 6 week, plan really to plan for. And I really like what Lisa said, and I highly recommend we say take 2 or 3 days after the release to not do anything and kind of hunker down at home, turn off the lights, get in the warm bath with the Epsom salts, turn down the lights, turn down the pace of life, do a lot of singing and humming and swaying and skin to skin and holding the baby and just doing a lot of comfort measures, because this is a lot of changes in the nervous system, not just in the structure, because my emphasis is not just on treating anatomy, but on treating physiology and function and how we move and engage our bodies in the environment. So then at the end of it, too, even though the end of the 6 weeks, we'll even say, like, you may want to come back and check in every so often, because there's this advancements and regressions that we see with babies. They get better, and then another developmental milestone comes up, and they may have trouble with that. And so it's like 3, 6, 9, 12, 15 months, maybe to come back for checkups even after that. And one other thing I wanted to say is 2 terminologies I think we need to get really clear on. One is the term revision is when you've done it over. So it's really, the first one is a release that we get. And if you have to have that done again, that's a revision. So just about a little bit about terminology, and it does matter. And then the term reattachment, which I would like to just completely chuck and get rid of and talk about, because what a reattachment is really just normal wound healing. So when we go in and we release it and we open up to a diamond-shaped wound, what we want to do is to have it fill in with a scar tissue and then stay that length. What happens when this reattachment thing is it just normal wound healing happens. And what we're trying to do after the release is to prevent normal wound healing from happening by lifting it up and making sure that this wound stays open several times a day. And mostly, hopefully, through a better latch, better breastfeeding, better movement and positioning, and like Jackie said, getting them out of positioners and infant furniture as much as possible, and getting them on the human body, getting them on the floor for tummy time, etc.
Great. Thank you for the clarification. I think I did say revision a few times, and I'm sure that that's used a lot, but it's right. It's a release that we're talking about. Revision would be the redo. Right, so great, really great. Let's move on to, I wanted to talk a little bit about, you started to talk, somebody was asking about videos of the stretches that are done afterwards. Is there anybody that has those videos that we can maybe post for anybody, or anything that you use to describe how to do the exercises within the mouth? And
I've got a YouTube channel, Michelle Emanuel, MICHELLE-EMANUEL. There's a couple of things there. I'm not a huge fan of like go to the YouTube thing and do it all on your own. I think there's a huge benefit to meeting with a professional who can use really astute eyes and observations, because I'm not also too about throwing the whole kitchen sink at babies. It's like we want to hone in with specific, what's going to work for this family, to have it be as compact and as less stressful as possible, because this is a stressful situation families are going through. Yeah. And in a sense, going through the procedure can add stress to the situation, but in the risk benefit, it's to make it better. And we know that. So those of us who are doing this for a long time, we see this and we see how it can turn out. And that's what gives us the confidence to continue working with families and say, yes, we can do this. And yes, this is how we do it, because we have, that perspective.
Yeah.
I agree with Michelle. I don't make videos. I really make it individualized based upon the family. And, you have to, like I said, pay attention to those parents, because you know what? You might have 10 things you want them to do, but they're only going to do one. So you have to figure out for that baby, what's the most important. And I usually will say, you know what? If you can only do X, Y, and Z, great. You're doing more than you were before you came to me. So that's great, and it's important. The other thing I just wanted to add to the aftercare, I know some providers will treat the baby, on mom during the sessions. I'm not sure how Michelle practices, but a lot of times I try to keep the baby where they need to be. So some babies, that's in mom's arms on the chair, when they sit in the rocker, and I treat the baby in their lap. Sometimes moms and babies lay on my table together. And sometimes I do work on mom too, because as I said, they're an energetic unit. They're together.
Yeah. As we move forward, did you have something to add? Go ahead, Lisa.
Yeah, I just wanted to say, because I see babies that are done by a couple of different providers, each provider who is doing the procedure may have different instructions. So to just go to a certain, YouTube video of something might be going against what a provider wants. And we've even, Scott and I have even worked out specific recommendations for my clients as opposed to others. For some reason, we see more reattachment the people that live where I am. And my theory for that is possibly inflammation, maybe more environmental pollution. I don't know if it's something in the water, but there's a lot of moms have a lot of inflammatory processes going on, and the inflammation will delay healing, or not delay healing, actually expedite healing in the baby. So we don't want the baby to heal too fast. I don't know if we were clear on that, because we want the wound to heal by secondary intention, not primary intention, meaning that, we don't want it, if it, like a cut, you want the cut to close up. With this, you want it to stay open. So it's tricky because babies heal so fast. Mm-hmm. So Scott will teach them the stretches to keep the wound open and the gentle lifting of the wound, which varies from provider to provider. So maybe, Scott, you want to jump on that?
Yeah, I mean, there's still a lot of research that needs to be done on this. Yeah. And I think in simple terms, like Michelle was talking about, we were just trying to keep that wound open as much or as long as we can to try to maintain the length of that, initial opening or incision or whatever you want to call it, just so we have an increased length and range of motion here. So, the faster those things close up, the shorter it gets, and kind of you're back to square one. And the wording is wrong. It's not reattachment. It's attachment or scarring or healing, normal healing. Right. So, the whole concept, I try to talk about concepts to the parents, just try to stretch, if you want to call it the diamond underneath the tongue or a triangle shape underneath the lip, to stretch it open. You don't have to do it forcefully. And there's, theories I go based on experience. We're trying to get science behind this, but when I used to do stretches that were more forceful and vigorous rubbing, I was seeing more scarring. More aversion.
I'm not even going to go into that at this point. Yeah, I'm not touching the wound at all. I know different people do different things, and it does depend on the tool that your provider is using, what you do for your aftercare as well, which makes it other YouTube things really hard to do because your provider may not be using the same tool, and there are different side effects and different things to consider, as well. And also the age of the baby is going to be a really big deal too.
Mm-hmm. Mm-hmm.
Yeah, so there's not a one size fits all for anything here. So that's, and even every family is different on how they can. Some are so timid with their babies, some are very forceful. So I think it's really important to sit there with the family, each family, and go over that with them.
Right, and even
I do have them videotape it.
Oh, and all that being said, I do have an Instagram, Tongue Tie Babies, and there's also Tummy Time for Tongue Tie. And we put a lot of information up and pictures and educational thing. But even with all of that and the parent even watching me do it, it's different because the parent doesn't have this motor program in their hands to lift the tongue up and to see the wound. This is maybe the first time these parents are doing it at all. And so even having them practice with you there, giving guidance and giving feedback, it reduces the amount of time I need to see them, which is good, but it increases their confidence. And that can't be done over YouTube or even, without the presence of another person who's educated.
I also wanted to ask very quickly, I know in New Jersey and maybe the surrounding areas further south, the more southern states to New Jersey, we're having a lot of babies who are going back for their checks to make sure that it hasn't reattached. And what we're hearing is that it's a mild reattachment, so we're going to pop it open. Do you understand what that means? Where they pop the actual incision open? Is that a common practice, or where you wouldn't actually laser it again, you just pop the incision open, correct? Because I think that makes parents nervous when they hear that, oh my gosh, you're going to be popping open something that I'm trying to heal for my baby. They don't understand it. So I think sometimes we have to be careful about the verbiage we use with parents, because that also adds to that stress level.
Mm-hmm.
So when I see the baby 2 or 3 days after the procedure, if the parents haven't been lifting the tongue and the tissue under the tongue is growing back already, I just do a stretch that should be done and it opens up.
Okay.
So a lot of times that might be what they're referring to. I mean, but that can only be done within a couple of days. because otherwise it's healed and you're actually doing a revision, So, but that happens a lot in my office, more than I want it to, because I hate having to do that to a baby,
I would imagine.
Well, because, and again, I'm a midwife, so I could be technically under my license, I could be doing the procedure myself. I don't, but I could be. So it's in my scope of practice to do this. Not sure it would be in, every IBCLC scope of practice. It's actually a procedure to, open up the tongue. But it's not really, it's just doing the stretch the way that, and showing the parents how to do it. When I do it the right way, it opens again.
Right.
Yeah, a lot of times if I see a baby that has been referred by Lisa and I see that that's kind of happening, I usually tell them that's out of my scope of practice, because most likely there may be a little bit of blood and probably a whole lot of discomfort, to be honest. And, I refer them to Lisa and I let her do that because it is more in her scope of practice. I try to do everything, like Michelle said, really gentle.
Right.
Yeah.
Definitely want to talk a little bit about, and I know we're getting closer to the end here, but I definitely, and you could see I'm making notes too, and we're going to be talking more in depth. We can go into each one of these topics in a lot of depth, which we will on some upcoming special events that we're going to do. As I was saying earlier, make sure that you're registered. I saw a few people in the chat room asking where they registered. Joe put the link up there for you. Many of you already did, but if you're registered, you'll get access to the downloads tonight. You'll also get the replay, and you'll also be on the mailing list so that you'll get information and a message when we're ready to do our next event, which is going to be a little bit more in depth than this one. But I definitely want to leave time for tonight to talk about misdiagnosis and long-term health effects, because we're not just talking about infants, we're talking about human beings and lifelong effects of this, whether it's through their speech or or feeding or whatever happens to come after. So Nancy, I really want to redirect that over to you and have you talk about that.
Okay, so in our practice, we do have lactation consultants on site. However, we don't actually get the babies, not all the time do we get the babies as newborns or infants. So where we come into play is when they're either failing after being released, where they're having these oral aversions from these aggressive exercises, or, trying to keep that wound open, and now the baby won't breastfeed and they won't bottle feed. So they're typically referred to us for this oral aversion work. Or we're seeing these kids who have been just plodding along this failure to thrive, I don't want to discredit pediatricians, but I think going back to the point we made originally, where we're going back to breast, which is wonderful, everybody's pro breastfeeding, but when it doesn't work for the moms, their first anecdote is to just give them a bottle, correct? So at least we see that a lot in our practice. And then the baby's failing at the bottle. So it must be the breast milk, and then mom is on a trajectory of elimination diets, correct? And then we go to formula because it must be something with mom's breast milk. So we go through the roulette wheel of formulas. It must be something, it must be a milk protein allergy. So we're going to go on an amino acid base formula, getting this kid to eat, still not eating, still failing to thrive, losing weight, and now we're left with, let's medicate. Let's put them on reflux medications. Let's do Zantac, let's do Nexium, let's do Prevacid, Prilosec, Pepcid, everything we could throw at this child, because that's what it probably is. They're not eating because they have reflux. They're not addressing the fact that they probably are swallowing the air. What they really need to do is look in the mouth and make sure that it isn't this tongue tie. So we're getting these older babies. I'm talking not just your late infants, not your 5-6 month olds. We're talking 9 month, 10 month. These kids are failing spoon feeding. They're failing their growth curves. And now they wind up in the hospital. They're doing all these radiological testing for upper GIs to make sure that the anatomy is correct, that they don't have fistulas, that they're having endoscopies for. These procedures, I mean, we're talking about feeding being stressful as it is already. And now we're putting on this medical trajectory for these children, and the parents' stress level is through the roof. And it's very difficult to bring everybody back to homeostasis, right? So I find that these parents are following the advice of their medical professional, their PCP, whoever it is that is taking them along this, and we're getting these kids who wind up with NG tubes, G tubes, with no other neurological conditions, no other disease process. They're normal, developing children who can't eat. They have failure to thrive. And then we get them, and we happen to do a great oral motor evaluation, and there it is, plain as day. Here's this tether. So,
hey, Nancy, you'll love this. I saw this baby yesterday, a 10-week-old, shows up in my office. He's been worked up at a local children's hospital for every ENT, pulmonology, hematology, GI, and they even put him under and did a scope, and no one looked under his tongue once. And he's got a significant posterior tie with micronaphia and airway patency issues and a horrendous case of reflux. And it's just really amazing to me that, I mean, I think that sometimes the workups need to be done, and sometimes we need to go to different levels, but the basics of a good oral exam, and to have somebody who's knowledgeable and educated, and that other comes to, like, you know, we've got people saying that there are ties, there aren't ties, when they're not knowledgeable and educated, and there are ways of looking at it in a very, you know, standardized way to say whether there's a tie or not. And it is based on function plus structure and everything in combined with symptoms as well.
You're absolutely right.
Yeah. So, you know, he had been and the mom was in her gut felt like that. And she said, please check him for a tie because I really feel like maybe that would be it. And just even said, no, he doesn't have one, but didn't really look under the tongue and get the tissues. And see, that's the thing. A diagnosis can't be made until you do see the whole structure and get the tongue into full range of motion without pulling the floor of the mouth up when opening the jaw.
Right.
And, you know, if those things cause a baby significant distress, there's no way they're going to be able to function in that range of motion. For feeding, for babbling, for moving their body, for exploring themselves, for feeling good about their digestion and their airway, for feeling safe in their bodies, etc.
Right. And ironically, what happens to be the go-to, you'll see that it's not just now this failure to feed properly or grow or gain or get on the growth charts. We see that they're delayed in rolling over. They're delayed. All the things that you've spoke to, you and Jackie, previously, we're seeing this with our kids. So now we get this medical community to sort of get on this spiral of there must be something else going on. So let's do neurology testing. Let's do all of these things. And it makes me a little insane, because I hear these stories from these parents who will say their child was otherwise healthy, maybe it was a late-term preemie, who was stuck in the NICU for 6 months because they couldn't get this kid to feed or do anything. And then the kid comes out who's perfectly, you know, fine, except for this tie, but now has a G tube, and I have to now tube wean and fix something that could have easily been identified as an infant. And this is what makes not only myself crazy, but all of my colleagues crazy, because these children are really being harmed by going this medical route. And I'm not saying that if their child definitely has a medical issue, it needs to be addressed. I'm all for that. I'm the first person to be advocating for your child. However, in lieu of anything else, if we have no other diagnoses and we're on this spiral or this trajectory we can't get them back from, just look in the mouth. And I can't tell you how many times I've heard, well, my primary care physician or my pediatrician said it wasn't a tie because the baby's able to stick their tongue out. I mean, literally. That's is like
not
a daily
the diagnostic criteria for tongue tie. Whether you can stick your tongue out is not. All parents listening, sticking the tongue out is not a criteria or diagnosis for tongue tie. And the emphasis should be on, it's on elevation of the back of the tongue to the roof of the mouth, the entire roof of the mouth, and the ability to go down and up easily without dragging the jaw on the floor of the mouth with it.
Right. And one a neonatologist had explained to me one time, and I think it's a great visual for people who may be in the profession or maybe just parents. You know, your system is a series of tubes and valves, right? So there's a valve beginning in your mouth and to the other end. We know that there's tubes in between there, correct? And we know that that process is a peristaltic waveform throughout. It should look like a fan, almost like the Rockettes at New York City. And that's how it should start, from the beginning of the tip to the end. If it's not doing that, then there is a problem and it needs to be addressed, or we're going to get these kids in a place that we will have a harder time getting them back from.
Mm-hmm.
So there's
That's
that.
That's how I teach, yeah. That's how I teach my residents and everybody. It's like, you know, you have to realize digestion starts in the mouth. If you're having a motility disorder in the mouth, maybe there is something else somewhere else. But, you know, how many of those patients that we've treated together that I've seen coming from major institutions like Hopkins or CHOP or whatnot that have gone through actual surgeries, you know, GI surgeries.
Right.
And it winds up being a tethered tongue.
And they're fine after we address the ties, right? How many cases have you and I had together that have been travesties, and all of these children, as soon as we released that tongue, the babies had a little work that still needed to be done, don't get me wrong, but it wasn't a medical case any longer. It was now just a functional case. It was reteaching, relearning how to work with the mechanism they weren't able to work with before. You know, and I get a little crazy and a little passionate, as we all do, when we find that you're trying to educate an institution of people who believe that, you know, I agree we need evidence-based medicine. I absolutely do. But it has to start somewhere. And I think as a group of professionals and our team, I think the passion that we all show with this, we need to be able to educate the other professionals and the families and the moms and the public to let them know that this is something that is very easy. You just need somebody to look at it and assess it and make sure it's okay before you start being okay. I have a hard time, especially today, having a family come in telling me that they were relieved that their doctor prescribed them a PPI, you know, reflux medication, because that was what was going to make it better. And this way they didn't have to go for any surgical release of the tongue tie. Now think about that, right? You would rather...
That's devastating. That's devastating when you look at now. We finally got research coming out that a shortened lingual frenulum is going to cause maxillary hypoplasia, meaning you're not going to develop your mid-face adequately. You're going to have a long, soft palate hanging in the back of your throat. It doesn't let our jaws and our teeth develop. Like, these are not just short-term issues. These are long-term health complications or cumulative stress problems. And, you know, addressing it in infancy doesn't even solve the problem exactly. You got to keep working on it throughout the lifespan, but it's certainly where we start our habits, you know.
Absolutely.
Yeah.
So did I answer you okay?
Oh, more than okay.
I'm going to jump off my soapbox now and then the others.
No, it's not a soapbox. It was so helpful. I think we need to hear this. Everyone needs to hear this. And I don't think that maybe more professionals understand this. I don't think, or maybe they don't, but a lot of parents don't understand that what the long-term consequences. And like you showed, Scott, you showed some images before of an adult man having a revision done or a release done. And, you know, this is something that can impact you throughout the rest of your life when it comes to the development of the jaw, the teeth, everything, breathing. Can you talk a little bit about that, any of you? Because beyond just the feed, I mean, obviously there's feeding, there's speech, and what else? Because I hear it, I'm sure you hear it, you know, it was mild, they told me to wait.
Right.
I'm going to be Scott's adult patient shortly because I have a massive posterior tongue tie. And I sleep just like Jackie described the infant sleeping, with my head upwards and in this sort of tortured position every night. I'm going to do it just because I need to do it for myself. And this way I can explain it better to our families too. right? I mean, wouldn't it be a great thing to be able to say, this is what it felt like, this is how I handled it, and this is how I think, all the kids should be able to do this if it's a problem. Obviously, I'm not having a problem feeding. That's not the issue. But I am having a problem with movement and with tightness and all of these other things. So I'll see you soon.
I would say some of my adult patients report that they have TMJ, like talking about feeding. Yeah, they do have feeding problems. Because as I said, here's an adult skull, right? So we talked about the tie, kind of pulling that jaw, right? So you might not get it fully out of the condyles, but you see how it's back. So you're getting a little bit of that happening. Here's your temporal bones. Here's your jaw, your temporomandibular joint. People get pain right at that TMJ. They could be grinders, grinding their teeth at night, clenching, right? You get a lot of tension, a lot of pain. Some people, your sinuses are here. You're getting congestion throughout your sinuses, right? Some people are also getting fluid in their ears, frequent ear infections, even as adults, migraine headaches. Again, just look at the structure and the anatomy. Migraine headaches, or coming from the cranial base up and around, because all of this is being pulled really tight. This is getting pulled back. This is getting compressed. So I see a lot of that. And then sometimes it even travels all the way into the ribs, down the back, into the sacrum with an adult, because it's all over. And that's how your body has grown and formed and developed. And we form these tension and restriction patterns that, yeah, you can release them. But again, talking about working as a team, you can release them, but if you're not releasing at the mouth, you're going to impact the body. And if you release just the mouth, but not the body, you're kind of missing out on that perfect balance.
Awesome. Yeah, well, I have it too. So just so you know, join the club.
So we'll make double appointments to see Scott and then follow up with Jack.
Absolutely.
Michelle, you're too far away, and Lisa, we're not breastfeeding, so there's.
No, but I also have studied oral myofunctional therapy, which is what you need as an adult to recover your tongue. So that's the other side of it. And, the sleep apnea part of it is what makes me the most concerned, because we can get through feeding, we could put Band-Aid, most kids will get through it. And then what happens? So, perfect example, I was bottle fed. I was, my mom would tell stories about how I vomited across the room, not to gross anybody out. But so I was definitely a baby who had issues, and I had my tongue tie revised 2 years ago, and I used the team approach with, I had some myofunctional therapy, some chiropractic. I'm still a patient of Jackie's, and some of those restrictions that she's talking about are what's going on in my own body. But I had mild sleep apnea. I have TMJ. But there are people that are having, total jaw surgeries and get major interventions when the issue is that the tie is tethered. And no matter what you do, that tie is going to pull everything back where it was, because the restriction is still there. So it's definitely, but it's affecting me. Procedure as a grown-up, there's more, there's habits that have been formed over the years, and different tightness patterns and things. Am I saying that right, Jackie? I don't do tummy time, no.
You should, Lisa. Tummy time is for everyone. Of all ages.
I wanted to add something that I didn't say when I was talking about some things you might see later in life. You also could see children that are getting diagnosed as ADD, ADHD, autistic spectrum disorders, because these children aren't sleeping. We're talking about sleep apnea, but let's explain. They're not getting a restful sleep. Their airway is compromised. Like Nancy was saying about how she sleeps. She's keeping her airway open. But what if a child wasn't doing that? What if their body wasn't compensating? And even if it's compensating, it's working hard. It's not getting the proper blood flow, proper cerebrospinal fluid, proper oxygenation. So you can get misdiagnosed also with a mental health neurological diagnosis when it's really related to oral structures.
Right. There's a lot of research going on with all of these things, and it's all connected. There's a whole cascading domino effect, when it starts as in utero and during embryologic development, and throughout when those tethers are not released, and especially as it relates to the airway as the central focus here, everything kind of really, I'm not going to get into all the details, but this is being really confirmed now. The experience is now being confirmed with science. The Stanford group has really put out a lot of, groundbreaking work, Christian Guimeno and friends over there that have corroborated what we see and what we do from the infants up through the adults. And then, that's what I see and deal with on a daily basis. And all the fascial connections between the tongue all the way down to the toes, in this domino cascading effect is really wild to see. It's real. It's not hocus pocus, as a lot of people think it is, and the science is now catching up to it, and there's still so much work to be done. But and I think that's where it's so exciting to be in this field at this point for all of us, because you actually see how you're helping families, from the babies up through the adults, and and working as that team. And now it's just it's a public health issue. And, as everyone chimed in here, Nancy drove it home that failure to diagnose or misdiagnosis, as I know, a few years ago, Jim Murphy, who's a pediatrician, IBCLC out in San Diego, gave that wonderful talk at the IATP meeting. And he really drove it home that, these pediatricians, not just pediatricians, but healthcare practitioners who are missing this should be held accountable. Just like we're held accountable for missing other diagnoses. This is a real diagnosis. And it's important.
Yeah.
Well said.
Well, I guess nights like tonight and all of you coming together and speaking out and educating, and we keep sharing the knowledge and keep talking about it, is only going to make things better, and hopefully get the research going more and just get more people aware. I think that's the important part. And I just loved seeing how many parents we had here, but really how many practitioners we had. And what I love about that so much is that for every single one that was here, it's hundreds of people that will be impacted by all of you spending the time tonight to give your expertise and have this conversation. So I really appreciate all of you being here. And we're not done. This is just the beginning. We are going to do something. I know there was so much good information, and I'm sure you guys could have all talked a lot more, and we all know that we had to keep it to a certain amount tonight. But we will be coming back to do more. I want you all to make sure that you're registered so that we can email you, let you know about any upcoming events that we plan, and keep posting your questions. There is a section on the page there where you register, where you can post questions, and that way we kind of know what you're looking to hear more about. It will help us a lot as we figure out what we're going to do next with this. So you guys, thank you so much for being here.
Thank you, Shari, for having us.
Thank you.
It was wonderful.
Everybody.
Yes, and thank you all in the chat room here. You were an amazing audience. I couldn't even keep up with the comments and the questions and everything else. And please go over to register, and you can get your downloads to all the great information to download and visit everybody's Facebook page and website as well. So we're going to say goodnight. It was a long night, and we got a lot in here. So good night, everyone, and good night to our panel.
Yay! Good night, everybody. Spending time with all of you.
You too.
Bye.